And first of all, I'd like to ask you to write in the chat if you can hear me, so that I know I'm speaking to people. Great, thank you very much. Just as you have done in the chat, you should be aware that you will not have speakers, microphones. So if you have questions or comments, we ask you to use the chat box, and we will make sure that that your questions are being heard by our speakers. And we also have Katarina online, who will help you with technical questions and difficulties. Like Kariman, I know I can see that you have difficulties. We will try to help you out. So without further ado, I will give the floor to my colleague, Dr. Agnes Lux, child rights specialist, to introduce the speaker of today's webinar.
Yes, hi everyone, and let me warmly welcome your guest speaker. We will continue our webinar series on Inspire with the third strategy, which is about this safe environments in order to prevent the violence against children, with managing communities and safe places for them, and also find the good intervention and response possibilities. Just a few lines back to the Inspire strategy. It was established or initiated by the WHO in 2016 in order to reduce significantly the violence against children globally. And our webinar series is about the 7 Inspire strategies and the promising practices related to the strategies. Today we have the luck and honor to welcome warmly Professor Jonathan Shepherd, who is a professor at the Cardiff University, a Stockholm Criminology Prize winner, and he contributed so many bills in the UK related to violence and prevention. He was also the founder of Violence and Society Research Group, and he will talk about basically about his child, the so-called Cardiff Model, which was identified in the Inspire handbook as a good practice on the safe environment strategy. Because the Cardiff Model is preventing violence using unique information from emergency health unit. They're using anonymized data, which can be used also to more accurate prediction of future patterns of violence and the identification of violence hotspot. So I think it's a very promising webinar today, so we are very happy that you are here, Professor Shepherd, and I really greet all the participants on the webinar, so feel free to ask the professor via chat box, and we try to answer your questions. Professor Shepherd, the floor is yours.
Thank you very much, and thank you for the invitation to present as part of the Inspire programme. Now, first of all, could you kindly all type where you're speaking from, which institutions you're speaking from, please? I'm just interested to know where you're all from. It's good to meet you, albeit virtually, but it'd be rather good to, right, there's a education institute there.
Yeah. So we have a global initiative to end corporal punishment. We have Center for Youth Integration, Serbia. We have Child Protection Officer, Serbia, NGO Indigo, the Albanian Coalition of Education, SOS Children Villages in the Middle East, Elena from Terre des Hommes and the others from the Terre des Hommes NGO in Egypt and Moldova. Partnership for Every Child, an NGO in Moldova. Croatia, Rijeka, Home for Children. Luca. We have Babiš Rutlac, Senior Child Protection Assistant at UNHCR. Darius, PSS Coordinator in Libya. So it's not even only Europe, but we have people from outside Europe represented.
That's great. Thank you very much. It's great to meet you all. And I don't want to highlight anyone in particular, but it's great to see colleagues here from Egypt as well, which is a country that I visited a few times. So thank you. So let's go on with my slides then. If I can just find the cursor to put it in the right place. So, and just to let you know that our Twitter handle is @ViolentSociety. You can see here. So do tweet if you'd like to as we're going along. So there we are. You've kindly done that. Thank you. So off we go. So violence is disfiguring. It's frightening. It blights cities. People don't want to come and work in a city where there's a lot of violence because they're afraid, and that has big economic consequences for their children and families and employees. And of course, violence, as we've seen in Syria and elsewhere, disrupts health services, and it costs us all a fortune. And it costs us a lot through our taxes because we have, as taxpayers, to pay for not just the police, but for emergency care in health and courts and prisons and rehabilitation for offenders. So that's by way of background. And here's another young person, which is actually, well, these are both patients of mine. As you know, I'm a maxillofacial surgeon, so these are both patients of mine. So this young lady, and I want to highlight the post-traumatic stress disorder, the anxiety, the depression, the sleep disruption, and flashbacks and all that. So it's not just about physical harm, it's about mental health harm as well. Now, and globally, you'll all know that violence is a major cause of death, especially for young people. So this is the 15 to 29 age group. This is global data from the WHO. And interpersonal violence here is the 5th most common cause of death amongst those aged 15 to 29 years. And that's excluding war injuries and excluding self-inflicted injuries as well. So it's a very important cause of death amongst adolescents. And of course, war injuries, which is not the subject of this presentation, is an important cause of death for children aged 5 to 14. So, and this discovery, which is highlighted in this slide, is the basis of almost everything I want to say in this seminar. And we depend, don't we, in many countries on the police to tackle violence, to prevent violence. But the discovery that we made years ago, which is really important, is that less than half of violent offences, less than half of violence which result in emergency department treatment, hospital treatment, are known to the police. So the police don't know about more than half of violence that results in hospital treatment. And following on from that, we found that police knowledge of violence varies by victim age and gender, and also by violence location. So for a 19-year-old boy or a 17-year-old girl who's injured, say in a nightclub or on the street, the police are unlikely to know about that because that offence will not be reported. But an old lady who's assaulted on the street, that is almost certainly going to be reported to the police. So the underlying message here is that we cannot depend on law enforcement and police to know about most violence. And that's the most serious violence, which of course puts people in hospital. So this finding has since been replicated in a number of countries. So this example is from Denmark, and Christian Fagerman, who is an emergency physician in an emergency department in Denmark, found exactly the same as we do, that the police know about a certain population of victims, and the hospital knows about another population of victims, but there's only very limited overlap. So the message that emerges from this is that if we want to prevent violence among children and young people, we must base that prevention on information, not just from the police, but also on the information from local emergency departments and emergency medical services. Now, you may think, well, this probably just applies to minor violence in which there's a cut or a laceration, or somebody's got a broken nose or something like that. But in fact, the research in the United States it especially shows that even a great deal of the most serious violence may not be known to the police. So Arthur Kellerman, he's a doctor in the emergency department in Atlanta, in the United States, found that almost 1 in 10 of shootings which resulted in emergency treatment were not known to the police. And in another study, this is in Memphis, Seattle and Galveston, and in Atlanta, he found that 13% of shootings which resulted in emergency treatment in his hospital were not known to the police. So again, even with the most serious violence, there's real basis here for preventing violence, not just on the basis of information from the police, but information from local hospitals as well. Now, you may ask, well, why is it that the police don't know about many of these serious violent incidents? And the answer to that question is that police knowledge of violence depends on people reporting violence to the police, but many people don't. We found in our research. This is Chris Clarkson, who's an academic lawyer who I worked with a lot in the past. People don't report to the police because they're afraid of reprisals. They may be gang members, they may be intoxicated, they may be carrying a weapon. In domestic violence, it's largely women, of course, but they may fear what their assaulting partner or husband may do if they go to the police. But it also applies to, say, the manager of a large nightclub. He's not going to want to report every incident of violence to the police because he'll be frightened that the police will be round to close down his club or restrict the sale of alcohol somehow in that club. And then the second reason is that people don't report to the police because people who are injured, they think, well, I don't know who hit me, who stabbed me, so what can the police do? So they don't go for that reason. And often as well, many people who are injured in violence don't want to have their own behaviour scrutinised. So I've mentioned already gang members, but people who are carrying weapons, people who are intoxicated, people who don't like the police for various reasons, that's another reason why a lot of violence is not reported. So this all points to the solution, which is the Cardiff Model for Violence Prevention, which is the subject of this webinar. So all that what I've mentioned so far suggests that we could use information collected in emergency departments to prevent violence. So that's the basis of the Cardiff Model, so that we can collect information and then use for prevention information collected in emergency departments. So this is all about violence prevention. This is not about violence surveillance or data for an annual public health report. It's information for practical, prompt violence prevention. Now, so could you please type yes or no to this question? Have you heard about the Cardiff Model for violence prevention before?
So we just...
That's great. That's great. Well, I can summarize that. So basically, about a quarter of you have heard of the Cardiff Model for Violence Prevention, and about 3/4 haven't. So that's very useful to know. And thank you for those responses. So now we go on to the next slide. There we are. So if we can, thank you very much. So what are the key features of this Cardiff Model for Violence Prevention, which depends upon information being collected in emergency departments? Well, the first feature is that information about violence, information relevant to violence prevention, is collected continuously and electronically by receptionists in emergency departments. So you may know of these as registrars. That's the term that's often used in the United States. But the basis of this is continuous data collection on precise violence location. So which street location was it? Which club or bar was it? Which school was it? Did it happen at home? Did it happen in someone else's home? What's the time of the violence? How many people were involved in injuring you? So was it one or more than one? And we find that if it's more than one, then that's a powerful signal of gang violence. And what was the weapon that was used? So then the second step is that all that information is anonymized. So it's not about sharing information about individual people or addresses or telephone numbers. This is about sharing information about violence location, numbers of assailants to find out if there's a gang involved, and weapon use. And that information is really hugely useful in violence prevention. This is not about telling the police about individual people. So all this information is anonymized, and then it's shared and combined with police intelligence, police data, and that's done by an analyst who then writes a report, regularly report, maybe every 6 weeks or 2 months, for the third really important step, and that is the use of this information, the use of these data for practical prevention by a violence prevention board, which I'll come on to a bit more. So step one is continuous information collection. Step two is the analysis and sharing of that information. And step three is the use by a violence prevention board of the data to prevent violence more effectively. So individual hotspots for violence can be identified through these hospital data. Now this shows a map of London, East London, population about 10-11 million people now, and on the right, as you're looking at this, these are the hotspots for violence that have been identified from police data, just police data. Now, looking at the left here, these are the violence hotspots which have been identified from emergency department data, the kind of data I've been talking about. And you can instantly see that when these health data are used, this injury data, then many more hotspots for violence shine out, they're identified. And these are completely invisible, or many of them are completely invisible to the police. So the police don't know about this one, or this one, or this one, or this one. The police know about this one. So the conclusion from this is that emergency department data, Cardiff Model data, will reveal for the very first time hotspots for violence which are completely invisible to law enforcement, the police. Really important lesson. If there's one thing perhaps to take from this webinar, it's this conclusion. It's very, very important. Now this, I want to move on now to an example of this from in terms of violence in which children are injured. So this is the Cardiff Model in Milwaukee in the state of Wisconsin in the United States. And so now for those of you not familiar with the geography, so just using this left-hand map, this is Lake Michigan. Chicago is down here somewhere. And this is the city of Milwaukee with a population of about 1 million people. And these are the hotspots for violence from police data, from the Milwaukee Police Department data. But these are the data, Cardiff Model data, from the large children's hospital in Milwaukee. And although some of the hotspots are the same, there is one hotspot here, one violence concentration, one location for violence, which is completely invisible to the police, in which children, this is just children because this is information from the Children's Hospital Emergency Department, is present. And this turned out to be a school. Now, we don't know where the next tragic shooting is going to be of children in the United States, but this gives us perhaps a clue. But most importantly, this information, which is unique, only comes from the Children's Hospital, enables the partners, education and the police and the school working together to reduce and prevent violence in this school, which is obviously a hotspot. So I think that's an important example as well. Now, could you please type any questions that you might have so far, please? No questions so far? Right, good. I'm taking that as a compliment to me. Yeah, so I think no questions so far, so we'll carry on, Katrina, if that's all right.
Mr. Jump in, there was one comment saying, my question is, sorry I missed the first part, who and how are these ED receiving data from? If you could maybe just repeat that part.
Let's go back. So this is how the data are collected. So a patient comes to the hospital, they see the receptionist or whoever it is at the front door of the hospital in the emergency department, and then that person, the receptionist or registrar as they're called in the United States, will then ask them, well, you've been injured, it's clear you've been injured, now was that violence or was it an accident? And then they will say, many of the patients, oh, it was violence. And then the registrar or the receptionist or the triage nurse, whoever's best placed to do this, asks the patient and the people that come in with the patient, well, where exactly did the violence take place? Oh, it was a school. What's the name of the school? Or it happened in the street. And then the receptionist would ask them, well, which street was it? And whereabouts in the street was it? So it was opposite the bus station in Tahrir Square, for example. And then how many assailants were there? And what was the weapon? So all this information is collected from injured patients, from injured people who go to the emergency department. Is that clear? Good. Okay. So let's carry on then. Now this is another example from Australia, so how do you prevent violence in a big city like this? And you almost all of you come from large cities, so this will be a common question. How do you prevent violence in a big city like that? Well, And this is the same map, only this here, we've got the hotspots for violence, where violence is concentrated, and it becomes a lot simpler. If we go back, this is complicated. Many potential locations for violence. But if we collect information from emergency department, we can identify these hotspots. And these two academics, this is Ross Hommel in Griffith University in Brisbane, and one of his PhD students, Dominic de Andrade, they concluded that the accuracy of targeted policing, for prevention purposes of course, could be significantly improved using information from emergency health services. So it's the same, this is the Cardiff Model in Australia, the same thing. Now, I mentioned near the beginning the importance of a violence prevention board in a city, which brings together different professionals, different expertise across a city. So this is me, and I had the privilege of chairing the Cardiff Violence Prevention Board in the County of Cardiff for 20 years. So these are the people who make up the Violence Prevention Board for my city. So these are police officers. This is a voluntary sector manager who manages a team of volunteers who work in the city centre. This is a police colleague of mine. I'm a surgeon. I'm not in law enforcement, but policing is really important. Here's our data analyst, and very important, because the information from emergency departments and the police needs to be analysed to identify, to discover, to reveal the violence hotspots. He's from public health. She is from the city government, and she's concerned with alcohol licensing in particular, granting licenses for the sale of alcohol and also for entertainment like rock concerts and all those sorts of things. This man is a nurse in our emergency department. He works in the entertainment business, so he represents all the bar and club managers in the city. She's another city government official, and he works with the police commissioner, so works for his boss, basically. So this brings together people from the local authority, from police and from health, in effect. Really important. And what we've found over the years is that as we've worked together, these people who do not normally meet begin to develop an accountability for prevention. So we're all here working for a safer city, preventing violence in schools, in the streets, in parks, in clubs, at home, and this accountability for prevention, this teamwork, gradually evolves and develops through the work of this board. Now, I wonder, do you have a prevention board or a child safeguarding board in your city? Could you type yes or no, please? Righto, that's coming out pretty clearly that about a quarter of you do and about 3/4 of you don't. So I would say that as a policy step, as a practical step that you could all take based on the WHO recommendation, is that you work with partners to develop a violence prevention board in your city. So just like this. Katharina, I think we can remove this now. Thank you. So as a practical step, I think this is very important. If you would like to prevent violence in your city, then bringing together a board like this is very useful. In fact, essential, I would say. Now, this arrangement is actually statutory. It's by law in the United Kingdom now. So every local authority, every police force, every health board has to work together in partnership like this. So these are the laws that brought those boards into position. And this actually is the badge for the first one that was developed in the United States in Atlanta around about 4 years ago now. So this is taking off in the United States, the Cardiff Model, and in fact the Centers for Disease Control in Atlanta, that's the public health agency for the United States, has recently adopted this Cardiff Model, so you can find information from the CDC in the links that Katharina and her colleague will have distributed to you. And there's a lot of there's a nice video in there and training aids and a brief description of the Cardiff Model if you'd like to access those. Now, so the next question really is, well, what kind of violence prevention are we talking about, and which the Violence Prevention Board can implement based on the data? And so these are a number of them. Targeted policing, closed circuit television in public spaces, disrupting drug supply and gang activity, alcohol licensing, because alcohol intoxication is such a powerful driver of violence, not just violence perpetration, causing violence, but also being injured in violence. And then various environmental interventions. So glass, we don't like to have glass littering our city streets because people can pick up a bottle or a glass and stab somebody easily. Park redesign, pedestrianisation of entertainment streets, stop and search by police looking for weapons. I should have added here interventions in schools. So police at the school working together to tackle violence which happens inside schools. Now, this is an important question. Does the Cardiff Model reduce violence? Is it evidence-based, as we'd say? What's the evidence that this really works? So that's this next section. So this is a graph of violence in Cardiff, in the city of Cardiff where I work, which has a population of about 500,000 people. And these are emergency department attendances by year from 2000 to 2018. And you can see here that there's been a steady decline, a few humps and bumps here, but a steady decline right the way through. So this is evidence that this is effective, because we actually started using the data, using the intelligence from emergency departments around about here in 2002, 2003. And I should say each of these dots is a weekly count, because this is 18 years and there's 52 weeks in a year, so there's 18 times 52 data points in here. Just in passing, I think that partnership between violence prevention and local university is important. So my own university produced this graph, and of course universities in public health and other health departments have the facility, have the resources to produce graphs like this and measure what's happening. But this is a controlled trial now. This is Cardiff is here. This is violence, serious violence here, the blue dots. This is the intervention city, Cardiff, and this is the mean values for violence levels in other cities, 13 other cities where the Cardiff Model was not implemented. So here we're comparing violence in the city where this information from emergency department was used with cities where information from emergency departments was not used. And you can instantly see from this that there's a big difference between the intervention city Cardiff and the control or comparison cities. And there's a gap here. Those of you who know about statistics will know that if these data points escape the error bars, it means that this couldn't have happened by chance. This difference couldn't have happened by chance, and that this is represents real prevention. And what's more, it's sustainable. So this is 2004, 5, 6, 7 in this trial. So in all these years, violence had been reduced significantly compared to cities where this Cardiff model was not in operation. So this is another way of describing exactly the same findings. So these are the blue columns here are the violence levels in the other 13 cities which are similar to the city of Cardiff. This is a graph from 2007, and here's Cardiff, and so this is the intervention city where the Cardiff model was first implemented, and it's become the safest city in this group of 14 other UK cities. So this is more evidence that this Cardiff model is effective. And in the intervention city in Cardiff, hospital admissions for violence went down, but in the other comparison cities, they went up. So that, of course, saves a lot of money, and it frees up hospital beds for people who really who need them just as much. This is a graph which was about homicide, and this was sent to me by Manuel Eisner, who is a professor of criminology at Cambridge University. And so this is a completely independent evaluation. And what he found was that homicides during the time when we were when we'd implemented the Cardiff model were going down in Cardiff in the intervention city, but up in all the other UK cities in Birmingham, London, Leeds and Edinburgh, for example. So this is evidence that the Cardiff model reduces homicide. We also carried out a cost-benefit analysis, and this was done by Curtis Florence, who's a health economist at the Centers for Disease Control in Atlanta. And I won't talk about these numbers very much, but effectively spend $1 and you save $152. So the cost-benefit ratio is very positive, very significant. Now, clearly, prevention costs something, but this is far outweighed by the cost savings here, which the Cardiff model produces. So the conclusion here is that this Cardiff model is very cost beneficial, saves us all money. Now, how does the model work? What do we think are the mechanisms through which the Cardiff model prevents violence? Well, first of all, it improves policing. If we know where the violence hotspots are, then police patrols can be redirected to so that the police are there at the hotspot. So when violence kicks off, when it happens, they can intervene and stop the violence, and that keeps people out of hospital. And of course, if the police are present at a hotspot, then that is going to have a deterrent effect as well, because people tend to behave themselves when there's a police presence. And then secondly, the Cardiff model prevents violence because it tells us a lot about weapon use, and that can be converted into weapon control. Perhaps unless you work in the United States, where firearm carrying is still very common. But a city that knows which weapons and where the weapons are being used can intervene with ones with metal detectors, with stop and search, for example, to control those weapons. And that's happened in many cities now, in Colombia, for example, in South America. And then the model also works because it identifies parks, walkways, is pedestrian thoroughfares, and schools where violence happens. And that enables the relevant authority, city government perhaps, the education department, to intervene in those schools and in those locations where violence is happening, especially in the Inspire programme where children are being injured. And perhaps a very recent example is in Kingston in Jamaica in the West Indies, where Cardiff Model data has identified a park where young people were being injured, and a park, a location which the police had no idea of. And then lastly, we think the model works because it allows hospitals in particular to identify people who are injured, children and adults, in domestic violence at home or someone else's home. And that enables the hospital to work with those injured people, they're largely women, but not exclusively, of course, to prevent repeat victimization. So the children may need refuge accommodation, they may need family support in some way, social support to prevent repeat victimization. So it's not that the model just works through better policing, it's through these other mechanisms as well. Now let's move on. Now it's very helpful if a national institution, a national body, a national organisation can get behind this scheme of things, and that's where the WHO and UNODC, for example, can have a really powerful effect. But this is another example. This is the guidance published by the Emergency Physicians College in the United Kingdom. The patron is the Princess Royal, who may be known to some of you. But the College of Emergency Medicine, this is the professional body for doctors who work in emergency departments, published this statement to basically say, you should be doing this. Your emergency department should routinely collect this information, this Cardiff Model information, so that it can be used for violence prevention, which is very useful, because this, of course, is something that doctors working in emergency departments will read very carefully. Now, I've talked about the model, but there are some pitfalls in this, which I think are worth just highlighting a minute. So the Cardiff Model, it's a very straightforward process. It involves information collection in emergency departments, anonymisation, sharing with an analyst, and then a violence prevention board to use that information to prevent violence. But if there is little or no leadership of this process, then the whole thing falls apart. Very important in your cities that senior people in education, in city government, in the police, in the local hospital work together to bring this about. It doesn't work if leadership is poor, or it doesn't involve executives who have the authority to make this happen. As always, data quality can be an issue. There's no point in collecting data which does not include the precise violence location. You need to know which street location it was, which park it was, which school. And if that data is not there, it's poor quality and can't be used. Then the analysis needs to be of a high standard. The information needs to be collected, needs to be joined together with what the police know, and then the hotspots have to be identified. And that means having an analyst, an existing analyst doesn't have to be a new post, but just someone who works it for the city government or the police, for example, or public health, who can do this analysis. Then the next pitfall is that the data need to be used. This is not passive surveillance. This is all to do with active violence prevention, which is what the Inspire model is all about. It's not just about sitting there and counting numbers. It's about the use of information for violence prevention. And everybody involved needs to know why the information is collected. So, for example, the receptionist or the nurse or the registrar in the emergency department needs to know that this information is being collected to make their city safer. Next one, I've said here, too much strategy, not enough tactics. So this is not, the strategy is the Cardiff model, but its use month in, month out, year in, year out, is all about tactical responses. It's about changing the police patrol routes. It's about better violence prevention in that school or in that street. It's not something that can be just left to the end of a year. And then the last pitfall, the last danger really with this, is that it's easy to complicate a simple process. The Cardiff model is a very simple process. It involves the collection of information, anonymisation, analysis of that information, and then use. And I've found over the years that it's very tempting for people to make this complicated, to say, well, perhaps if we collected information about, I don't know, ethnic origin of the patient, or was alcohol involved, then it becomes too data heavy, and those data aren't reliable anyway. Those data aren't going to show you new ways of tackling violence. So when you implement this in your city, in your area, beware of complicating what is basically a simple process. And so this is my last slide, apart from asking you if you've any questions. There's quite a lot of international implementation of this model now. It's happening now throughout the United Kingdom, in Scotland and England and Wales, and but the first country overseas to take an interest in this was the Netherlands, Holland. As I've mentioned, this is being implemented now in the United States. It's being implemented in 5 cities in Australia, in Sydney, Melbourne, Canberra, and a couple of other cities, and in the Western Cape area of South Africa, also with the townships on the Cape Flats area of the Western Cape. It's also being implemented. And of course, the WHO has endorsed this approach, and that's why we are gathered here today to talk about it. So thank you very much for listening, and it just remains for me to ask you if you could kindly type any remaining questions, please.
Much for this excellent presentation. And from the chat box, I already have 2 questions to you. One is, how do you get hospitals who are overburdened as they are to contribute and report the data?
This problem has been a problem in. Can you hear me all right? Yeah.
Yes.
Shall I carry on, Katharina, and answer that question? Yeah. This is a problem in the United Kingdom as well, and we evaluated various ways, different ways of collecting the information. And we found that doctors and nurses are too busy to do this. But the real opportunity comes with the reception staff, with the registrars as they're known in the United States. They do have time, and they're there receiving patients, and they're typing in to their IT system the name of the patient, the address of the patient, their telephone number, why they're there. So it's very easy, we found, for them to just ask these 3 or 4 more questions. Well, where did it happen precisely? How many people attacked you? Time, what time was it? Was it yesterday? It was yesterday at 3 o'clock in the afternoon. And so that is typed in, and there was maybe 3 attackers. And that all takes less than a minute for the receptionist to type in. So, and emergency departments are very busy in the UK as well, but that's the way we found, that's the opportunity. So it's using the receptionist to record the information. So that's the answer to the question.
Thank you. And another question was that you mentioned police and health, of course, but what other institutions need to be involved in the partnership?
Yeah, I think basically the local authority, the city government, needs to be involved. But the right answer to the question is that it depends on what the data is showing you. If the data is showing you that violence is happening in a certain school, then you need to get that school on board, or the head of the local education department in your city. Now, we learned a lesson from the Cardiff Model implementation in Atlanta in the United States, and there the data showed that a lot of violence was taking place in a shopping mall, a shopping precinct. So the manager of that shopping mall was then invited onto the Violence Prevention Board. And then also in the same city, the data from the emergency department showed that violence was concentrated where there were cheap hostels for bed and breakfast, cheap accommodation for people. So the manager of that hostel, that very cheap, low-grade hotel facility, was invited onto the board. So I think you need the three basic partners. It's the hospital, the local government, education department, perhaps particularly in your case, and the police. But added to that, you need to have the other agencies which can make a difference based on the data that's coming through. And that those are going to be different.
Thank you. Another question is, what types of analytical tools and skills are needed for the data analysis so that it's effective in the model?
Yeah, the analyst needs to be able to, on a spreadsheet, identify each individual violent incident. And then the analyst, or the hospital really, needs to take all the personal identifiers off the data. So it's not, as I've said, about sharing information which identifies particular people. You know, we don't want the police running around and knocking on people's door and saying, you were injured and went to hospital yesterday, didn't you? It's not about that. It's not about adding cases to the criminal justice system. And then I think the analyst needs to be able to make maps, to construct maps electronically, so that the kind of maps that I've shown you today can be put in front of the Violence Prevention Board or the police or the schools authority to say, these are the hotspots that we need to identify. So it's very simple, straightforward analysis, really. But the construction of maps is important, so that provides a visual representation of where the violence is happening.
Let's see if there are more questions coming still. I can see a participant writing. So Darius mentions GIS and SPSS, I guess, as programs that are used for data processing.
GIS not important.
Yeah, GIS not important. GIS is not important because patients, they don't know the coordinates where they were injured. I'm not a statistician, I'm a surgeon, but GIS is not so important, not important at all. And this is not about statistics. SPSS may be useful, and most analysts have SPSS skills, but this is not for research purposes. Remember, these are simple data for prevention. It's not for a research paper.
Ariman asks that, of course, institutions have a responsibility to report violent cases. Like hospitals probably have also a legal responsibility to refer these cases further, no?
It depends. Most countries don't have the laws like that. And in the United States, there are some states which have enacted, which have legislated, but the evaluations show that that doesn't make a difference to violence prevention. That mandatory reporting by hospitals to the police does not prevent violence. And I think it's also, from an ethical point of view, hospitals are not part of the criminal justice system. Hospitals are not police stations or part of police departments. You know, our hospitals need to be safe havens for people to go to be injured, to be treated for their injuries. And if people think that they're going to be interviewed by a police officer when they go to hospital, they're not going to go to hospital. They're just going to sit on the street or at home, and who knows, they may die because their injuries are not treated, for fear that the hospital is going to report them to the police. So I think we need to be very careful not to think of hospitals as police stations, police centres. They're not. They're safe havens for treating people who are injured, whether they're offenders or victims or whoever they are. But we still need to collect this information so that the police can prevent violence more effectively.
Thank you very much. Our time is coming to an end, so I would ask Agnes to close our session. And thank you very much, Professor, for the excellent presentation.
Thank you very much. It was like we have been in a university lecture in a very good way. So thank you very much again. And for the others, I would like to say that we will have a next webinar on the last week of January, around this 30th of January. We will have talking about the sixth strategy of the Inspire. It's about the response and support. We will have a Georgian speaker, Miss Maya Megalashvili, who's the World Vision Georgia, who are running a street children project. They are supporting the street children through World Vision programming. So it will be a really interesting project from the field, let's say so. So I would like to say that please follow the newsletter to see all the details of the next webinar. But let's continue this series, and we will meet the last week of January again.
And just to say that under the web links, you also have one that's called the Barnahus webinars. It's a series of webinars where you can find recordings of them, because the Barnahus is a very famous model that corresponds to the response mechanisms when children are victims of violence. But there are a number of webinars already that you can refer to. So please refer to the web links in the window down. Thank you very much, and I hope to see you all next time.
Thank you. Very nice to see you all. I think we can. I don't know if they want to carry on. We finished.